This session is titled Must Know Clinical Images for the Boards. My name is Dr. Ajay Singh. I'm a member of the Renal Division at the Brigham and Women's Hospital and Senior Associate Dean for Postgraduate Medical Education at Harvard Medical School. These are my disclosures. And this is my bio. So the first case is a 64-year-old man who was admitted to this hospital with fever, dyspnea, and acute kidney injury. Presents with a 4-day history of fever, approximately 39 degrees centigrade, and shaking chills. There's no chest pain, orthopnea, or leg swelling. No history of recent travel. He's worked as a bus driver, but has had no known contact with anyone with confirmed SARS-CoV-2 infection. He has a history of diabetes, hypertension, coronary artery disease, and obesity. Temperature on exam is 37.9, blood pressure 122/80, non-orthostatic, heart rate 105, respiratory rate 42, oxygen saturation 94% on room air. His BMI is 38. His labs at the time of presentation is a creatinine of 1.8. 1 year earlier, the serum creatinine was 0.8 milligrams per deciliter. His chemistry show a potassium of 4.6 milliequivalent per liter, a phosphorus of 2.6. His complete blood count was within normal limits. His INR was 1.2, CK was 22. His COVID PCR is pending. His lateral flow test for the antigen is positive. The urinalysis shows no hematuria, but does show trace proteinuria. His urine sediment shows muddy brown cast, and a renal ultrasound reveals no hydronephrosis. And on the left-hand side, you see a representative chest X-ray, and you see that there is these opacities in a diffuse manner in both middle and lower lung fields. And so the question is, this patient has COVID-19 and acute kidney injury. The most likely cause for the acute kidney injury is A, volume depletion, B, ATN related to COVID-19, C, collapsing glomerulopathy from COVID-19, D, COVID-19 related microangiopathy, and E, acute obstruction. And the correct answer is ATN related to COVID-19. And the reason for this is that physical examination doesn't suggest that he's volume depleted. His urinalysis doesn't show a tremendous amount of proteinuria and doesn't show a nephritic or a nephrotic looking urine sediment with lots of red cells or a red cell cast. The COVID-related microangiopathy is not supported by his complete blood count or his hematological parameters, and acute obstruction is ruled out by the normal ultrasound. Now, the COVID-19 associated acute kidney injury has become an established part of the presentation of acute COVID-19, of the COVID-19 clinical syndrome. Here, in a consensus statement by the Acute Disease Quality Initiative, ADQ work group, Mitra Nadeem and colleagues have really talked about and spent a lot of time thinking about COVID-19 acute kidney injury. The four things that are identified in the mechanism of acute kidney injury are shown on the right-hand side: endothelial injury, SARS-CoV direct infection of the renal tubular epithelial cell, causing acute tubular necrosis, volume-related ATN, or even volume-related hemodynamic acute kidney injury, and coagulopathy. On the left-hand side, you see that the COVID-related illness has an asymptomatic phase, a symptomatic or respiratory phase, and then a multi-organ involvement phase, which involves a significant host response. And the mechanisms are either direct, with direct viral effects shown on the left-hand side of the schematic, or indirect effects shown on the right-hand side. And in this patient, it's clear that there appears to be acute tubular necrosis, most likely related to a direct effect, since the patient didn't seem to be volume contracted. A number of studies over the 2 years of COVID-19 have been published, many of them from Wuhan and from New York, where the experience is the greatest. And renal injury is truly an established part of the acute COVID syndrome that we see patients present with. And in a few studies, they've looked at mortality, and depending on the severity, underlying risk factors and the severity of the disease, the mortality can be quite high, as much as 30 to 50% mortality. This is shown here in this retrospective observational study of 3,393 hospitalized patients from Mount Sinai Hospital in New York City. The acute kidney injury rate was 46%, those requiring dialysis 19%, and there was a 50% mortality in AKI patients versus only an 8% mortality without AKI. And the risk factors that were predictive of a worse outcome included CKD, male gender, hyperkalemia on admission, probably all of them, except for the gender, indicating a more severe presentation. And then you see on the in the schematic bar diagram the different types of stages of acute kidney injury that these patients present with, and you can see that the most severe forms of acute kidney injury is shown in beige in the middle column, occur in patients who have been admitted to the ICU. Case 2 is a 69-year-old woman with a 3-month history of malaise and weakness, who presents with anemia, hemoglobin of 8.9, diffuse achiness in her bones, and on workup, a serum creatinine of 3.8 milligram per deciliter. A renal biopsy is performed, and the question is, what is the diagnosis here? And you see on the left-hand side, the kidney biopsy, you see the tubules here and the tubular interstitium. And the options you have are A, light chain deposition disease, B, phosphate nephropathy, C, uric acid nephropathy, D, CAS nephropathy, or E, fibrillary glomerular nephritis. And the correct answer is CAS nephropathy. And the reason for that is that you see these fractured, broad, large casts with this eosinophilic material in these dilated tubules. And this is typical of a patient with CAS nephropathy. And so CAS nephropathy occurs in patients with multiple myeloma. Multiple myeloma is the malignant proliferation of plasma cells involving more than 10% of the bone marrow. Bone marrow related to multiple lytic lesions is the most common clinical presentation. Up to 30% of patients are diagnosed incidentally while being evaluated for unrelated problems. And a third of patients are diagnosed after a pathological fracture, commonly of the axial skeleton. Mechanistically, there's an overproduction of light chains that results in an excessive amount of these chains being light chains being excreted and exceeds the tubular capacity for reabsorption. Filtered light chains and immunoglobulins then bind to TAM horsefly-glycoprotein, which is secreted in the medullary thick ascending limb of the loop of Henle, and subsequently cast formation and obstruction occurs in the distal nephron. Now we move on to case 3. This is a 52-year-old woman who underwent thoracoabdominal resection of a right adrenal cancer. A right periadrenal lymph node dissection was done, and resection of the inferior vena cava was done. The baseline creatinine in this patient was 0.9 milligram per deciliter, but 10 days after surgery, the patient presents with right flank pain, foul-smelling brownish drainage from her drain that had been in place from the time of surgery. Her blood pressure is 140 over 82 millimeters of mercury, temperature of 100 degrees Fahrenheit, a white count of 17.89, and a hematocrit of 22.9 with a serum creatinine of 1.6. And the question is, what does this patient have? And what you see on the left-hand side is the CT scan. You see the kidney here. On the right-hand side, you see the kidney. On the left-hand side, the liver. And just to orientate you, this is the spine at the bottom. On the right-hand side, you see the perfusion scan, and you see the perfusion for the left kidney and perfusion of the right kidney as a whole. And then below that is the cortical perfusion of the left kidney and cortical perfusion of the right kidney. And so the questions is, what is this syndrome? A, Alagili syndrome, B, Page kidney, C, Benjamin syndrome, or D, Brody's abscess. And the correct answer is Page kidney. So let's talk about Page kidney. So in 1955, Engel and Page reported a case of hypertension associated with a renal subscapular hematoma in a football player who had sustained blunt trauma to the flank. And indeed, this was the first clinical correlate to Page's 1939 study of hypertension induced in dogs by wrapping one or both kidneys with cellophane. So compression, Page found, of kidneys in these dogs was associated with hypertension. And in essence, Page syndrome is where any external compression of the kidney causes renal hyperperfusion and ischemia. Causes include bleeding secondary trauma, surgery, a cyst, or a tumor. Now, CT of the abdomen, as shown in the case that's presented, is the preferred imaging modality because renal ultrasound may not be sufficiently sensitive to detect a small compressive subcapsular hematoma. In this case, you can see up here the subcapsular hematoma, and it's easily detected, and so it would have probably been detected by renal ultrasound. In the case presented here, the MAG-3 renal scan was used to assess the differential or split renal function and showed this discrepancy between perfusion in the left kidney, which appeared to be relatively normal, and perfusion in the right kidney. All the other syndromes are really just there as noise, and this patient has none of these syndromes. Let's move on to case 4. This is a 58-year-old man with a 12-year history of hypertension and hyperlipidemia who's referred for management of a serum creatinine 1.4 milligram per deciliter and a urine albumin creatinine ratio of 3.8 grams per gram creatinine. The patient's already being treated with lisinopril 40 milligrams per day, amlodipine 10 milligrams per day, and furosemide 40 milligrams per day. A renal biopsy was performed a year back, and that's shown on the left-hand side here. On examination, the blood pressure is 132/60, heart rate 70, and on physical examination, there's a trace to 1+ lower extremity edema. And the question here is, what is the next best step? A, tell the patient that other than better control of his diabetes, he's on the right treatments. B, tell the patient that an SGLT2 inhibitor and a mineralocorticoid receptor antagonist should be considered, something like finerenone. C, tell the patient that a referral for kidney transplant evaluation is needed. D, perform another kidney biopsy to confirm the diagnosis. Or E, consider adding an angiotensin receptor antagonist to his treatment regimen. And the correct answer is, tell the patient that an SGLT2 inhibitor and an MRA should be considered. And the reason, before we move on, the reason for that is this patient has type 2 diabetes and has a very poor control of the diabetes, but has quite substantial amount of the proteinuria. And so what you see on the left-hand side is a nodular glomerular disease process, and these nodules are linked in N, and this is a patient with diabetic kidney disease. And so the best treatment for this patient is further and more aggressive control of both diabetes and blood pressure and managing progression of kidney disease. And the best agents now for that would be an SGLT2 inhibitor and consideration of adding in a non-steroidal mineralocorticoid receptor antagonist. Obviously, there might be some concern that in the background of angiotensin inhibition, that adding in non-steroidal mineralocorticoid receptor antagonists might be associated with hyperkalemia. So you've got to do this cautiously. You've got to watch the potassium, and you may actually need to use a resin such as Lokelma or Veltassa to further reduce the potassium by binding exogenous potassium before it's absorbed. Nonetheless, I think more aggressive therapy is needed. Case 5 is a 39-year-old homeless man who presents to the emergency department with anorexia, nausea, vomiting and oliguria. 5 months earlier, he had stopped attending his regular hemodialysis sessions. On examination, his blood pressure is 167/80 millimeters of mercury, lethargic, slowing of speech, and he has lower extremity edema. His breath smells of a urine-like odor. And the question is, what's the diagnosis? And you see here the patient up here. This was published as a clinical image in the New England Journal of Medicine. This patient has these white crystalline material both on his face but also on his body. And so the differential diagnosis is retention keratosis, B, uremic frost, C, eczema, or D, post-inflammatory desquamation. And the correct answer is that this patient has B, uremic frost. It's very unusual to see this. I've not really seen many cases myself, even though I've seen many hundreds of patients presenting with advanced uremia. Uremic frost was first described by Hirschsprung in 1865. It's rarely seen today because of early dialytic intervention. In fact, if your program is a good program where early referral is done and initiation is done in a timely fashion, you really shouldn't be seeing this. And the exact incidence is not known. What happens here is the concentration of urea in the sweat increases greatly when the blood urea nitrogen level is high. There's evaporation of sweat with high urea concentration that causes urea to crystallize and deposit on the skin. To verify the crystals are composed of urea or nitrogenous waste, scrapings of the frost can be diluted in normal saline, which can then be tested for elevated urea nitrogen levels, which are then found comparable to blood levels. The next case is case 6, and what you see here on the left is crystals in the urine, and the question is, the urine sediment shows what form of crystals? A, oxalate crystals, B, cysteine crystals, C, uric acid crystals, D, struvite crystals, or E, acyclovir crystals. And the correct answer is B, cysteine crystals. These crystals are usually hexagonal, classically so, as you see here, translucent and white, and they're not completely without this sort of disform appearance in the middle of the crystal. Cysteine crystals occur in patients with cystinuria. Cystinuria is an autosomal recessive disorder caused by mutations in the SLC3A1 and SLC7A9 genes. These genes encode 2 parts of a transporter protein in the kidneys. Now, under normal circumstances, the protein allows certain amino acids, including cysteine, to be reabsorbed into the blood from the filter fluid that will then become urine. As the levels, however, of cysteine in the urine increase, the crystals typical of cystinuria are able to form, and you see these crystals in the urine, and in more advanced cases, we'll see kidney stones. Now, this is an interesting a clinical image that was published in the New England Journal of Medicine. It was a 37-year-old person presenting with cystinuria who also had other forms of urinary crystals. So you see the hexagonal cysteine crystals here, again shown with just deformity here, but hexagonal crystals here. But you also see rhombohedral triple phosphate or struvite crystals. You see triple phosphate crystals, which when viewed under polarized light result in where the triple phosphate appears polychromatic. And in this patient had a UTI 2 weeks before presentation, which was treated. Causative organism was not known. But as you know, triple phosphate crystals associated with urease-producing organisms. Now, this is just a schematic that shows a different appearance of different types of crystals. Uric acid crystals have lots of different appearances, but this is one example. Calcium oxalate, the envelope-shaped, hippuric acid crystals shown here. This pointed crystals. Calcium phosphate, the very typical appearance. Triple phosphate has a coffin appearance, and ammonium biurate has this very sort of almost like squid-like appearance. And then there are other types of crystals, of which I just want to share with you the cysteine crystal, which is hexagonal with this abnormal-looking thing in the middle, or deformity. And then the acyclovir are these sort of thin, spiky crystals that have a very typical appearance. Let's move on to case 7. This is a 22-year-old woman who presents with joints and abdominal pain and a rash. Rectal examination is positive for occult blood. The urine shows hematuria, and the question is, what is the most likely diagnosis? This is a patient's pre-tibial area, and you see this hemorrhagic petechial rash, purpuric rash, and here on cells, you see some fuzziness around the red cells, compatible with the presence of some degree of dysmorphic appearance. And so the question, what's the likely diagnosis? A, renal cell cancer, B, renal infarction, C, kidney stone, D, Goodpasture syndrome, or E, Henoch-Schönlein purpura. And the correct answer, of course, is D, Henoch-Schönlein purpura. It isn't going to be Goodpasture syndrome, although you can get dysmorphic red cells in Goodpasture syndrome, but you wouldn't be seeing in Goodpasture syndrome this sort of vasculitic rash that's more typical of a small vessel vasculitis. And in Henoch-Schönlein purpura, that will present not only on the skin, but also will present in the small bowel, and patients may present with pain. This patient in the differential diagnosis, renal cell cancer is not going to give dysmorphic red cell, not going to give a rash. Likewise, renal infarction, not going to do this. Kidney stone might result in hematuria, but it's not going to give you a rash. And we discuss the other options. So the patient has palpable purpura and hematuria. The red cells are precrenated. This is typical of dysmorphic red cells. The combination of the clinical presentation and the hematuria makes HSP the most likely etiology. Henoch-Schönlein purpura, or HSP, is an IgA-mediated small vessel vasculitis that predominantly affects children but can also be seen in adults. HSP is a subset of necrotizing vasculitis characterized by fibrinoid destruction of blood vessels and resulting in leukocytoclasis. The pathology is that of an IgA nephropathy. This is on the left, light microscopy. You see expansion of the mesangial area, and when you look at this biopsy under immunofluorescence, you see IgA lighting up very prominently. So this patient has an IgA nephropathy as the cause of the glomerular disease and therefore of the hematuria. HSP nephritis clinical features can be divided in four buckets, if you will. The skin manifestations, a purple, non-blanching urticarial rash with purpuric papules that might become confluent, and this is when you do a skin biopsy. This is a leukocytoclastic vasculitis. As we've discussed a minute ago, the GI manifestations, abdominal pain in about 2/3 of cases. This is usually a small bowel vasculitis, but you can also see vomiting in association with subabdominal pain, diarrhea, periumbilical pain. Major complications are quite rare. Intussusception and bowel ischemia and necrosis quite rare. The renal manifestations much more common in adults than in children. Only 1/3 of children have renal manifestations. 2/3 of adults of those patients who present with HSP have renal manifestations, and this includes hematuria with dysmorphic red cells, macroscopic, microscopic hematuria, of course, proteinuria, and abnormal kidney function. You get joint abnormalities with arthralgias, not arthritis, so there's no deformities, arthralgias, and periarticular edema in about 2/3 of patients, involving the knees, ankles, elbows, and wrists, so large joints, not small joints of either the hand or the foot. Let's move on to case 8, and the question here is, what is the most likely diagnosis? And you see a picture here on a plain radiograph, a KUB, of both kidneys with calcification. And the question is, what's going on here? A, is it renal tubular acidosis? B, primary hypoparathyroidism? C, familial hypocalciuric hypercalcemia? D, salicylate overdose? Or E, Paget's disease? And the correct answer is A, renal tubular acidosis. Now, this patient doesn't have primary hypoparathyroidism. That is a result in hypercalcemia. Familial hypocalciuric hypercalcemia, by its very essence, is going to have very low amounts of calcium in the urine, although the patient is hypercalcemic. Paget's disease and salicylate overdose can cause or be associated with abnormalities, but not going to be associated with abnormalities, metabolic abnormalities, but they're not going to be associated with this chronic hypercalcemia and hypercalciuria that's going to result in what is seen here, which is nephrocalcinosis. So this patient has bilateral symmetric calcification of the renal parenchyma, sparing only of the renal pelvis, as you see here. This patient had been diagnosed with renal tubular acidosis at the age of 9, but did not undergo medical follow-up, unfortunately, until this patient was 20 years old. The other listed choices are non-common causes of nephrocalcinosis. Renal tubular acidosis, a quick review. There are 3 types: type 1, type 2, and type 4. Type 1 is the location here of the abnormalities in the collecting tubules. Type 2, it's the proximal tubules. These 2 are the renal tubular acidosis. Type 4 RTA is really an adrenal disorder. In type 1 and type 2, acidemia is present. In type 1, it's severe. The potassium in type 1 and type 2 as renal tubular acidosis both associate hypokalemia. The pathophysiology in type 1 is failure of alpha intercalated cells to secrete hydrogen ions and reclaim potassium, whereas in type 2, it's failure of proximal tubular cells to reabsorb bicarbonate. Whereas in type 4, you get hyperkalemia, and this is because of a deficiency of aldo or resistance to its effects. Now, distal RTA is the classical form of RTA. It was the one that was described first, and it's basically failure of the alpha intercalated cells to secrete hydrogen ions and potassium. So this is type 1 RTA. Results in hypokalemia, hypocalcemia, hyperchloremia. Urinary stone formation related to alkaline urine, hypercalciuria, and low urine citrate are typical. And long-term untreated, this can cause nephrocalcinosis, and also long-term can cause bone demineralization with rickets in children and osteomalacia in adults. Let's move to the next case, case 9. What you see here is immunofluorescence and shown of a glomerulus. And the question is the most likely diagnosis: A, idiopathic focal segmental glomerulosclerosis; B, diabetic nephropathy; C, membranoproliferative glomerulonephritis; D, microscopic polyangiitis; or E, anti-GBM nephritis. And the correct answer is, of course, anti-GBM nephritis. And you see the ribbon-looking linear deposition on immunofluorescence, typical of someone of a patient with anti-GBM nephritis. Described by Dr. Ernest Goodpasture, and the syndrome named after him. He was a resident of the Mass General Pathology Department who was moonlighting at the Chelsea Naval Hospital, who reported autopsy findings in young sailors. In 1958, Stanton and Tang used the term Goodpasture syndrome to give credit to Goodpasture, who described this originally, and it basically said that this syndrome comprised of pulmonary hemorrhage and glomerulonephritis. In 1964, Shear and Grossman reported linear staining on immunofluorescence. And the basic information about this, it's very uncommon. 1 case per 10 million in the population, 1 to 2% of all kidney biopsy specimens in busy nephrology practices. There's a slight preponderance in males, but that shouldn't distract you. There's no age association. While there is a bimodal distribution, it really can occur in any age. Somewhat more common in whites over African Americans. About 50 to 75% patients have an upper respiratory prodrome and may have fever, rash, myalgias, malaise, headaches, or weight loss. But in truth, much less likely to have any of these symptoms or physical findings. When you see these findings, you think about a small vessel vasculitis like an anchor vasculitis or an overlap syndrome. Renal presentation is with rapidly progressive glomerulonephritis, which is defined as a doubling of serum creatinine within 3 months or a 50% reduction in estimated GFR. Proteinuria does occur, but usually not nephrotic proteinuria. There isn't enough time for such a explosive syndrome, and likewise hypertension, because of the same reason, is uncommon, as is the ultrasound normal kidney size, but renal function declines rapidly as part of the syndrome of RPGN. Moving on, case 10 is a 48-year-old white male with chronic kidney disease and a serum creatinine 1.5 milligram per deciliter. Presents to you complaining of weakness and fatigue and an episode of palpitations. The patient's on furosemide, lisinopril, atorvastatin, and aspirin. You do an ECG and draw labs. Based on the ECG, what's the most likely diagnosis? You see here the 12-lead ECG. A, patient has hypomagnesemia, magnesium of 1.4. Patient has hypocalcemia, potassium of 2.0. This is roughly where you think the patient is. Patient has hyperkalemia, roughly at 6.8. Patient has hypocalcemia with a lowish total calcium of 7.1. And the correct answer is shown here, which is that this patient has hypokalemia. And you see these U waves, typical of a patient with hypokalemia. This patient does not have my hypomagnesemia. The patient does not have the tenting of T waves compatible with hyperkalemia and does not have the electrocardiographic features of hypocalcemia, all of which we're going to go into in a few minutes. And if you look at this EKG in more detail, you can see this almost like notching. This is a patient with a U wave. And so when you see a patient with a normal ECG, this normal hypokalemia is shown here with a U wave, hyperkalemia with a tenting, hypocalcemia here, and hypercalcemia here. And you see this patient has a prominent U wave or hypokalemia. Hypokalemia, the PR interval may be prolonged. There's a flattening of the T wave and a prominent U wave. You can sometimes see ST depression and QT prolongation, but it's often difficult to measure because the T wave flattens. Let's move on to case 11. This is a 20-year-old man who presents with edema and has a past history of 2 episodes of painless gross hematuria at the age of 16 and 18 years of age. Denies joint pains, mouth ulcers, hemoptysis, abdominal symptoms. Examination is normal, and he has a blood pressure other than that of 148/92 and a 2+ pitting edema bilaterally. Urinalysis shows 2+ blood and 4+ albumin. Sediment shows many dysmorphic red cells, but no cellular cast. Complements are normal. The kidney biopsy shown here, at the top here is light microscopy, bottom is immunofluorescence for IgA. The most likely diagnosis is lupus nephritis, Wegener's granulomatosis or polyangiitis, IgA nephropathy, anti-GBM nephritis, or minimal change disease. And the correct answer is this patient has IgA nephropathy. This IgA nephropathy has a clinical onset usually in the 20s or 30s, a preponderance of males rather than females. Predilection for whites and Southeast Asians, particularly from Singapore. Not clear whether this predilection for Southeast Asians is because they do more frequent biopsies in patients who present with hematuria, but the data is the data. Less common in African Americans. There are some familial and HLA associations. Patients can present in 4 different syndromes: macroscopic hematuria, microscopic hematuria, rapidly progressive glomerulonephritis, or nephrotic syndrome. Patients who present with macroscopic hematuria, most of these patients are pediatric patients, less so adults, can have a synpharyngitic presentation. So unlike post-strep GN, where there's a two-week lag or thereabouts, a 2-week lag, and these patients, the synpharyngitic thing is that they get a pharyngitis that revs up the mucosal immune system, and then they develop this, they usually present with a macroscopic hematuria. These patients will have recurrent gross hematuria, varying levels of proteinuria, but progression tends to be slower, have a better prognosis. Microscopic hematuria, maybe because it's less easily detected, and so detected late in the course. There's proteinuria. About a third of patients have hypertension. About a third of patients have azotemia. These patients have faster progression. Moving to the next case, this is a 12-year-old patient. This is case 12. This is a 56-year-old woman with hypertension, presents with sudden onset of painless impaired vision in the right eye. On the previous day, she had undergone cardiac catheterization for evaluation of a hypertensive emergency. On physical examination, the visual acuity in the right eye was 20 out of 100, with significant visual field defects in the inferior temporal quadrant. And you see here the appearance fundoscopically, and you see this whitish area that's like a sail. And the question is, what does this patient have? This patient, of course, has cholesterol embolism. The image demonstrates cholesterol emboli with surrounding white lucency representing retinal edema. Fluorescein angiogram confirmed occlusion of the cilioretinal artery with non-perfusion of the tissue bed in the hypofluorescent areas. And this patient had cholesterol emboli. This is shown here. You see this here, these cleft-like crystals, crystals that are released in the arterial bloodstream from ulcerated or disrupted atherosclerotic plaques. It can be the initial sign of vascular disease. And in this patient, you see this. So oftentimes you might have loss of the pulse here in the feet, and then you set this reddish bluish discoloration. Cholesterol embolism syndrome should be suspected in any patient who develops worsening renal function, hypertension, distal ischemia, or acute multisystem dysfunction after an invasive procedure. It tends to occur more commonly in middle-aged elderly people because they tend to have more vascular disease, more common in men than women. There's a stepwise rise in the serum creatinine, and usually the urine is bland. That's the classic presentation. But in a series by Bazzari et al., they actually noted that some of these patients can actually also have an active sediment. And this is shown here, these cleft-like crystals in a medium-sized artery of the kidney. Moving to case 13, this is a 64-year-old patient with end-stage renal disease on hemodialysis who presents with an ulcerated painful lesions shown here. She says it started off as a reddish rash and then evolved into an ulcer over a few weeks. So the most likely way to reach a definitive diagnosis would be A, surgical exploration of the wound, B, a C. diff toxin assay, C, a skin biopsy, D, PT and INR, so hematological evaluation of coagulation, and E, lupus serologies. And the correct answer is C, skin biopsy. This patient has, as you can see, this blackish discoloration. This is shown also in the pretibial area. This patient has calcific uremic arteriolopathy, otherwise known as calciphylaxis, because in 1 to 4.5% of patients on dialysis, the classical clinical picture is that of an initial skin lesion, livido reticularis-like appearance on the lower limbs, which then progresses to a violaceous, painful plaque or subcutaneous nodules that are followed by ischemic or necrotic ulcers of the reticular pattern. Differential diagnosis is a necrotizing fasciitis or a pyoderma gangrenosum, coumadin or warfarin necrosis, and SLE. Patients will often present with severe pain, non-healing ulcerations, and this manifests often in recurrent hospitalizations. Most common in patients who are in their 50s, particularly women, more so than men, and more common in white patients. Unfortunately, without treatment, and nowadays the treatment often involves local care, but also sodium thiosulfate, but without treatment, the one-year mortality is terrible, 40 to 80%. Skin biopsy usually confirms arteriolar calcification and mural thrombosis associated with septal paniculitis. Treatment, as said here, local wound care and metabolic control, avoiding tissue trauma, excessive manipulation, prescribing systemic antibiotics where needed. Surgical debridement is controversial because you may actually increase the risk of sepsis and worsen pain. Often the traditional teaching is correct the calcium phosphate, keep the product less than 55. It's controversial about whether you normalize the PTH by doing a parathyroidectomy. Much more popular nowadays is sodium thiosulfate, where you dissolve the insoluble calcium salt embedded in the tissue. Doses of 5 to 25 grams are given intravenously over 1 hour post-dialysis. And there's also some role that has been suggested for bisphosphonates. That's it. Thank you very much for participating in this, and I wish you the very best. Thank you.